What is the most common disease in the United States? Male pattern hair loss. No! It is hypertension. What is the most common cause of congestive failure? Hypertension. What is the most common risk factor for coronary disease? Hypertension. What is the most common risk for peripheral arterial disease? Hypertension. What is the most common risk for stroke? It's hypertension. What is the most common risk for end-stage renal disease? Hypertension. What is the most common risk for anything in a blood vessel? It's hypertension. Now, I would rather have hypertension than diabetes. Actually, overall, I'd rather have none of them. But if you have to choose one, I'd rather have hypertension. Why? Because if you have 1,000 people with just hypertension and 1,000 people just with diabetes, and you look at the rate of heart attack at 10 years, diabetes is much worse to your vasculature, much more damaging, but hypertension is more common. Now, what is the most common cause of hypertension? Why, it's essential. What do you mean it's essential? It's the most common disease in the country. We spend $6,000 per person plus in the United States. Double what they spend in the UK, Germany, France, Canada, Italy, Japan, and Australia. It's the most common disease. What causes it? Why, it's essential. What do you mean it's essential? You don't know what causes the most common disease with the most expensive aspect of the private market? You can't tell? It's essential. You gotta have it. You got to have it. Now, what does essential hypertension mean? Well, people used to think like this. You have a stroke, you got clogged up blood vessels. The body's natural response is to increase perfusion pressure in order to get blood into your brain and your heart. They said like this, you can't lower the blood pressure, it's essential. Now we know it's the opposite. The heart disease is caused by the high blood pressure. The stroke disease is caused by the high blood pressure. So the blood pressure causes the damage. We used to think that the high blood pressure was a reaction. That's why it was called essential hypertension. Now, in the general population, the normal population, let's say general population, it's very clearly defined as being a blood pressure greater than 140/90. And if a guy has a blood pressure that's a little bit elevated, you repeat and you repeat and you repeat. See where it says multiple readings? Because this is what we know. It takes somewhere between 3 and 6 times for blood pressure to come to its steady state. So therefore, we need 3 to 6 times, multiple. I'm not in any hurry to start treatment either. Because when I start treatment, when am I going to stop? Just after death. What do you mean after death? Well, I'm an internal medicine doctor. I like to give you the last dose just after death. One for the road. So therefore, when do you stop? At death. So I'm not in any hurry to start. I'm not in any hurry to start. You see this where it says quote-unquote white coat hypertension? I hate that term. That's like I'm responsible for your anxieties? Look, I got enough anxieties of my own. How come I'm being held accountable for yours now? Well, white coat hypertension means that if you measure the blood pressure, it takes some time for it to come to its normal state. Well, what happens if you have the nurse take the blood pressure? It still takes 3 to 6 times to come to its normal state. It's just a little bit lower because they're scared of the nurse too, but just not as scared as they are of you. Now, this thing about never labeling a person as hypertensive with one reading, that's if they're asymptomatic. If you're acutely symptomatic, if you have acute visual disturbance, shortness of breath, confusion, these people don't need multiple readings. So the multiple reading thing is for the asymptomatic person. Now, if you're going to say how long, they can't ask you exactly how long. See here it says several months. That's because we can't tell you how long. It's not definite. Several months. You're not in any hurry. Don't be in such a hurry. Now, this is for an asymptomatic person. Look for the symptomatic person. The hypertensive crisis people, these people are very easy. It was labetalol and nitroprusside 25 years ago, and it's labetalol and nitroprusside. Now, IV enalapril, hypertensive crisis, urgency, emergency. Hypertensive crisis, urgency, emergency. Those people get treated, they get treated now. They get treated now because they don't repeat. So hypertension. Now this next fact is a huge fact, and that fact is something must have happened to the sound. What happened to the sound? This most essential fact is It's the most important fact. Good. Next slide. No, that most important fact is this, that when you have somebody who has diabetes or has some evidence of renal involvement, that cutoff is less than 130/80. That is a big deal. That's going to be tested. They're going to ask you, muy importante. The other thing is here, you see the 160/110? If you have blood pressure that's so high, 160/110, you're not going to be able to be controlled with just one drug. So that's why that's important. You can't get that much benefit out of just one drug. Now, look at the presentation here. The vast majority of people with hypertension have no symptoms. Did you get that? No symptoms. Did you get that? No symptoms. And all you do is you find it on routine screening. If you have acute symptoms, it's a hypertensive emergency, urgency, hypertensive crisis, accelerated hypertension, and those people have to go straight to therapy. Labetalol, nitroprusside, IV, and allopril. Now, with essential hypertension, we're looking at the urinalysis. Let's look at the first one. Urinalysis, we're looking for protein. What will we do differently based on that? Give them an ACE inhibitor. Hematocrit, why? Measure of renal dysfunction. Potassium and creatinine and creatinine, these three things, 2, 3, and 4, 2, 3, and 4 are really saying, has the hypertension killed your kidney? The ECG, what are you going to see on an ECG? Left ventricular hypertrophy. Left ventricular hypertrophy. What will you do differently? Not much, because you're going to control the blood pressure anyway. Glucose. A lot of people go, what has the glucose got with hypertension? Hypertension doesn't cause a hyperglucose. No, you're doing it because to see if they're diabetic hypertensive, because you're controlling the blood pressure lower. One, you're going to give an ACE and an ARB. Number two, the target is less, 130/80, 130/80. Why the lipids? Again, multiple risk factors, but the lipids you don't do anything differently based on. All right, now the tough thing is here, what do you do about prehypertension? You see this, what happens when it's not a 140/90, but it's still a little bit up? The fundamental issue is you are not giving these people medications most of the time. Telling people lifestyle modifications. And what is your favorite lifestyle modification? Weight loss is the most effective. Weight loss is the best. For each kilogram lost, you're going to lose 1 millimeter of mercury off of your systolic pressure for each kilogram you lose. What are you going to do differently based on prehypertension? Lifestyle modifications. What are you going to do differently based on blood pressure of 160/100? 2 meds. 2 meds. Now, the initial drug of choice. I repeat. And my drug of choice. Ready? It was a thiazide diuretic 30 years ago, and it's a diuretic now. Now, whether to go to a beta blocker, a calcium channel blocker, an ACE or an ARB, angiotensin receptor blocker, does not really matter if the person has no other organ damage. They have a myocardial infarction, beta blocker. Severe depression, try to avoid beta blockers. A diabetic, ACE inhibitor. Migraines, beta blocker or calcium blocker. How do you choose then? Look at other diseases. I'm an asthmatic, not a beta blocker. I'm a diabetic, yes to the ACE. I have a cough with the ACE, cough with the ACE, cough with the ACE. Angiotensin receptor blocker. Losartan, valsartan, irbesartan, candesartan, telmisartan. Losartan, valsartan, irbesartan, candesartan, telmisartan. You have 4 different classes of drugs that are all essentially equal. How are you going to choose? Other indications. Asthma, no beta blocker. MI, yes, beta blocker. Depression, no beta blocker. Coronary disease, yes, beta blocker. Congestive failure, yes, beta blocker. How will I choose? Well, individualized treatment means that you are basically looking at the other diseases. You have an MI, beta blocker is good. Decreased LV function, beta blocker good, lowers mortality. Now, the single most teratogenic medication in cardiology is the ACE inhibitor in the person who's pregnant. So ACE inhibitors and ARBs are contraindicated. Now, why are we still saying alpha-methyl-dopa? The real answer for pregnancy is Definitely no ACE and ARBs. Definitely no ACE and ARBs. Definitely no ACE and ARBs. Diuretics are relatively contraindicated. We're worried that it might cause a little low birth weight. Little low birth weight. Little low birth weight. Why? Shunts blood away from the placenta. Shunts blood away from the placenta. However, the only truly contraindicated ones are ACE and ARBs. Why alpha-methyl-dopa? Traditional. I pledge allegiance to the United States of America and for the alpha-methyl-dopa for the pregnant women for which she stands. One patient, under a uterus, indivisible from their alpha-methyl-dopa, because we know it's not teratogenic at all. Okay. Now, why is it that we're treating hypertension? We're treating it because, you see this? What happens in the long term? I have a heart attack. I got congestive failure. I have left ventricular hypertrophy. Why am I doing this? To prevent a stroke and renal failure and retinopathy. Now, this is preventing hypertensive retinopathy. The only way to really prevent diabetic retinopathy is to control the glucose. This is to prevent hypertensive retinopathy. Oh my God, look at that big, thick left ventricle. Get me a beta blocker. Get me a beta blocker. What's the difference between hypertension causing a hypertrophic cardiomyopathy? What's the difference between a hypertrophic cardiomyopathy and a hypertrophic obstructive cardiomyopathy? What is it? What's the difference between hypertrophic and hypertrophic obstructive? I think it's the obstruction. Yes, that's it. This is a congenital disorder. This is a thickening of the septum. And this is a person who gets syncope and sudden death. Both of them get treated with beta blockers. Both of them get treated with beta blockers. But this one causes obstruction, syncope, and sudden death. And hypertrophic cardiomyopathy just means that we have hypertension. This is diastolic dysfunction. I got a good ejection fraction, high ejection fraction. I give a beta blocker to relax my ejection fraction. Aortic aneurysm here on the back of the heart. Aortic aneurysms in the abdominal aorta above 5 centimeter surgery. 5 centimeter surgery. It's not as clear in the thoracic aorta. Same picture, looking at the aneurysm. And now this is a chest, but in the abdomen, 5 centimeters cut me. 5 centimeters cut me. Okay, a myocardial infarction is trying to say, well, we get left ventricular hypertrophy. The thicker the heart, the more likely it is to have a myocardial infarction. It has an increased oxygen demand. Now, peripheral blood vessels also. The same way that we want to, in peripheral arterial disease, give an aspirin, control the lipids, control the blood pressure. Coronary artery disease, we give an aspirin, control the lipids, control the blood pressure, control the glucose. Strokes, we give an aspirin, control the lipids, control the blood pressure, control the glucose. Aortic disease as well. It's the same for all of them. It's the same for all of them. LDL, less than 100. Blood pressure low, control the glucose, give an aspirin. Same answer. Now, a hypertensive emergency means that you have acute symptoms. You have acute symptoms. You have symptoms of decreased perfusion of vital organs like your brain and your eye. See blurry vision, chest pain, shortness of breath? Chest pain, shortness of breath, engine confusion. Chest pain, shortness of breath, engine confusion means you're not getting enough perfusion. Chest pain, shortness of breath, hypertension, confusion means you're not getting enough perfusion. Better give me some labetalol and nitroprusside before a stroke. Next slide. You see this white coat hypertension? You can't get end organ damage from artifact. People who are anxious with the doctor can get a high blood pressure, but they can't get a stroke and shortness of breath. They can't get retinopathy from it. It was nitroprusside and labetalol, and it is nitroprusside, labetalol, and IV enalapril. You don't lower more than 25% of the mean arterial compression. Do not lower too far. What does too far mean? You've gone too far. Man, do I hear that a lot. Okay? You've gone too far again! Man, wow, this is interesting. As an intern, they used to call it insubordination. Now they call it leadership. Now they say, you've gone far. Can you take us with you? Oh, well, what is meaning going too far? 25%. No more than 25%. The blood vessels, they get hypertrophic. I need extra blood pressure to push through. Yeah, I got big muscular blood vessels. If you lower the blood pressure too much, they close off completely and you have a stroke. Don't lower too far. Don't go too far, or you can provoke a stroke. How do you know that a person has essential hypertension or some secondary correctable cause? 95% of hypertension has no known etiology. 5% has a potentially correctable etiology. In whom should we look for Conn's syndrome, Cushing's syndrome, pheochromocytoma, accommodation of the aorta, closure of the renal artery. Oh, bless you. Oh, bless you too. Closure of the renal artery stenosis. Cons, Cushing's, pheochromocytoma, closure of the renal artery. Contraceptives. What type of contraceptive? A condom tied around the aorta? No, oral contraceptives. Oral contraceptives. One more, what? Look for a hairy woman who needs a waxing bad, who's not Greek. The non-Greek woman with a waxing deficiency. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia. Yes. So in whom should you go looking for these things? People who are young. What does young mean? What's young for you? Young for you is under 30, I think. Young for you would be under 30. Yes. Young is, what would be old for you? Old for you be, I think over 60. Yes, over 60. Okay, if they're young, if they're old. You know, if you're 22, you shouldn't be having hypertension. If you're 72, you shouldn't be having hypertension. Someone who is hard to control. Someone who is hard to control. Or someone who has a characteristic physical finding. Someone who has something characteristic in history and physical that tells you it's there. Something who has something characteristic in history and physical that tells you it's there. Conn's syndrome, hypokalemia and weakness. Pheochromocytoma is episodic flushing and palpitations and headache. Episodic flushing and palpitations and headache. Episodic flushings and palpitations and headache. Coarctation is upper extremity blood pressure greater than lower extremity blood pressure. Upper extremity blood pressure greater than lower extremity blood pressure. Upper extremity blood pressure greater than lower extremity blood pressure. Closure of the renal artery is a bruit. You mean a noise, a sound? Why, yes, it is a sound, a noise. But it's always sexier in French. You have such noisy flanks. Your CVA is talking to me. You're so noisy in your flanks. A noise? No, a bruit. Bruit. A bruit. Okay? A bruit. Oh, yes. Do you want to twist around a point or you don't want to torsade des points? Do you want burgers or Berger's disease? Well, I'd rather have a bruit than a noisy flank. Contraceptives and people who are rather hairy. People who are rather hairy with hypertension, congenital adrenal hyperplasia. How do we tell somebody has secondary hypertension? They're either young or they're old. They've got something in the history and physical that's telling you it's there. Or they've got some aspect of there that makes it hard to control. Something has to be telling you. Remember, step 2, if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. That means that if they want you to answer that question, what is the most likely diagnosis, they better put something in there to tell you. I'm not a mind reader, you know. You got to tell me. Secondary hypertension. Let's look at some slides. First of all, who should be screened? What does it say? What do we mean here by very young? That's interesting about very old. After all, 40 is pediatrics. Okay? So very young means under 30. Those with a key feature of, okay, that means key feature of a particular case is what is meant by something in the history. You have a person with muscular weakness and hypokalemia, Conn syndrome. You have somebody with truncal obesity and stria, buffalo hump, osteoporosis, Cushing's. Episodic palpitations, headache, flushing. Episodic headaches, palpitation, flushing. Episodic headache, palpitations, and flushing. Someone here, coarctation. I'm big, strong, and muy macho up here, and a teeny weeny, ittle witty big guy down here. Upper extremity greater than lower extremity blood pressure. Now, in the elderly, renal artery stenosis, which of the following is the most common cause of secondary hypertension? A, B, C, D, E, F, G, aha! Which of the following is the most common cause of secondary hypertension? The answer is renal artery stenosis. Now, what we see here is that renal artery stenosis, elderly people have atherosclerotic disease, and it causes a narrowing of that renal artery. Younger people have fibromuscular dysplasia. The muscular lining of the intima is hypertrophied. And a bruit, remember, only a sum of the patients have a bruit. 30 to 50% have no bruit. 30% have no bruit. Now, renal artery stenosis. What you should get first for renal artery stenosis, what you should get first for renal artery stenosis is a sonogram. Then you can go to any one of 3 tests. What we see here is 3 tests. Captopril-renogram. Angiography is the most accurate. Duplex sonogram, MRI angiography. Well, you look at all this mess of tests here on a slide, boy, there's a list of 4 or 5 things there. This is listed in the sort of standard way you would find in a medical school. But gosh, that slide itself wouldn't ask to allow you to actually answer a question, because after all, the captopril nuclear renogram, the duplex ultrasonogram, and the MRA are essentially all 3 equal. They're essentially all 3 equal. All 3 of those are equal. The nuclear captopril renogram, the MRA, and the duplex ultrasonogram are all 3 equal. Ready? Duplex ultrasonogram is the least accurate in a person who is obese. There's a lot of me, and all so luscious. I dote on myself. There's a lot of me, and all so luscious. Each moment and everything that happens thrills me with joy, for I am larger and better than I thought. I did not know that I held so much goodness. I am larger and better than I thought. Well, what if you are larger? Duplex sonogram won't show you the stenosis. You know why? Because as there becomes more obesity, you can't see the artery. Captopril nuclear renogram is inaccurate if you have renal insufficiency. Renal insufficiency means that the nuclear isotope is not being excreted. Renal insufficiency means that the nuclear isotope is not being excreted. So you ready? All 3 of these are equal. However, not in all patients. Obese, not the duplex sonogram. Renal insufficiency, not the captopril nuclear renogram. MRA is good, but the most accurate, single most accurate, is angiography, arterioscopy, okay, arteriogram. What is the best initial therapy? Renal artery angioplasty and a stent. Angioplasty and a stent, angioplasty and a stent. You see here when it says ACE inhibitors? Well, ACE inhibitors, which don't prevent renal failure, are only to control the blood pressure. You might say, well, Dr. Fisher, I heard that ACE inhibitors cause renal failure in renal artery stenosis. That's true, they do. But if you can't correct somebody with either balloon angioplasty or surgery, and they got very high blood pressure, you're giving the ACE inhibitor to just control the blood pressure. But doesn't that mean the kidneys will fail? Yes, but the kidneys would fail anyway. but at least it keeps the blood pressure low and keeps your brain from failing too. Your heart from failing, your eyes from failing, keeps you going blind and stroke and heart, blind and stroke and heart, blind and stroke and heart. That's why we're given the ACE inhibitor. The angiotensin levels are enormously high. You won't let me fix you. You won't let me do surgery or you fail surgery. You won't let me do angioplasty or you fail angioplasty. I've tried angioplasty. I tried surgery. Nothing works. The blood pressure's high. Yes, your kidneys are going to fail anyway, but at least you won't have a stroke while we're doing it. So we give the ACE inhibitor simply to control the blood pressure. What do we have here? Oh, Conn syndrome. You know, Americans don't like eponymous names that much. Even Lou Gehrig's Lou Gehrig, right? But we don't call it Lou Gehrig here. We don't like that. We don't like eponyms. Okay, immortality through naming your name after a disease. So we use the medical type of name. So instead of Conn's, people prefer primary hyperaldosteronism or amyotrophic lateral sclerosis. Now, if you have congestive failure, you're intravascularly volume depleted. Your renin level goes up. If you're dehydrated, your volume depleted, your renin level goes up. You have low albumin, your volume depleted, your renin level goes up. You have congestive failure, dehydrated, hypovolemic, hypotensive, your renin level goes up, your aldosterone level goes up. Your renin level goes up, which drives aldosterone. Renin, angiotensin 1, angiotensin 2, aldosterone. But what if you have a high aldosterone level and the renin is normal? It's like, yo, what's that, man? Your aldosterone is up, but where's the renin? And the answer is, how could that be up without the renin? Because it's a primary hyperaldosteronism. A primary hyperaldosteronism. Anybody who has a high renin can have a high aldo. But how do you get a high aldo with normal renin? Primary hyperaldosteronism, Conn syndrome. Now remember, aldosterone makes you retain sodium and excrete that potassium. So if you have too much aldosterone, you're excreting, potassium level goes low. Now what is it that people with low potassium show up like? Yeah. My potassium level is so low. Can I have that potassium? Low potassium. Muscles heavy, man. My arm feels like it weighs 400 pounds. Why? No potassium, no neuromuscular transmission. No potassium, no neuromuscular transmission. I could have wonderful, large, perfectly shaped deltoids, but I can't use them. Oh, that sucks. That sucks. So hyperaldosteronism, unilateral adenoma, sometimes hyperplasia, less than 1% cancer, less than 1% cancer, less than 1% cancer. You have an elevated aldosterone, and in diagnosis here, it should also say elevated aldosterone with a normal renin or low renin. Elevated aldo with a low renin. 85% are an adenoma. 80% to 95% are an adenoma. Cut it out. Bilateral hyperplasia. I can't cut out both your adrenals. I can't cut out both your adrenals. Let's block it with a potassium-sparing diuretic. Keeping it mysterious here. That slide keeps it mysterious. Which potassium-sparing diuretic? I like to keep the mystery in this one. That would be spironolactone. That would be spironolactone. That would be spironolactone. Keep the mystery in that. Now, pheochromocytoma. Oh yeah, 10% bilateral, 10% malignant, but the major issue is this. Pheochromocytoma is the episodic. You see that word? Episodic, 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 episodic. Watch, hold still, hold still. Poof! Look at that. See how episodic suddenly became much larger? It's like animation. Ping! Popped up like that, episodic. Episodic. Why? Because suddenly it's popped up as the single most important word in the case. Look, boys and girls, what's the difference between being with Papa here and studying on your own? Because all the words and all the information sounds the same. Pheochromocytoma is a generally non-malignant disease, the adrenal medulla, resulting in the increased release of epinephrine and norepinephrine from the adrenal medulla. This results in episodic hypertension with palpitations, headaches, it all sounds the same. It all sounds the same. That's too many words to memorize. What's the point of doing it here? So we change it like this. Pheochromosoma is the episodic release of epinephrine and norepinephrine, results in the episodic elevation in blood pressure with episodic flushing, wheezing, and diarrhea. Look, there are a lot of you out there in front of this videotape right now that have higher IQs than me. Plus, you don't have all these sort of messy emotions like I do gumming up the works. But look at this sentence here. You see, if you see episodic hypertension with headache, sweating, palpitations, tachycardia, that's 8 and 9 words. Well, give me a little news flash. All causes of hypertension give you a headache. A lot of people sweat. Cameraman sweats and he doesn't even have pheochromocytoma. Okay? Lots of people have palpitations. You can have palpitations for no particular reason. Ay, Dios mío, yo tengo palpitation. Ay, yo tengo mareo. Ay, catch me, I'm falling. Ay, Dios mío, ay, que lástima. Well, lots of people have palpitations. My mother had palpitations for 22 years. She didn't have pheochromocytoma. She was married to my father. She got divorced and palpitations went away. Tachycardia. You know, I recently asked my mother, I told my mother, she said, do you mention your father by name? I go, no. She goes, too bad, too bad. So the issue is, my mother did have palpitations for 22 years. She didn't have pheochromocytoma. She didn't have hyperthyroidism. She didn't have Graves' disease. She didn't have an electrolyte abnormality. Just a subjective sensation. So all those things are true about this disease. Let's look at the slide. Episodic hypertension, palpitations, sweating, tachycardia, blah, blah, da, 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 da. But the moral of the story is all cause of hypertension. Why do we do it like this? Why not just read in a book? So that you can say like this, you may be twice as smart as me, but if you're memorizing 9 words there, and I'm memorizing only 1, you may be twice as smart as me, but you're not 9 times as smart as me. Episodic hypertension, get me a VMA and a metanephrines. VMA and metanephrines. VMA and metanephrines. Vanilla mandelic acid. I always like that word. Sounds like something to eat, right? Oh, that looks tasty. Let's have some vanilla-flavored mandelic acid. Tasty. Okay, ready? Epinephrine is changed into metanephrine. Is changed and metabolized into VMA. Okay, the VMA. Now, see, epinephrine is changed into metanephrine. Changed into metanephrine. Changed into metanephrine. Do you know what the Greek word meta means? Change. Changed into metanephrine. What does it mean? It means change. Metaphysis, change in growth in the bone. Metaplasia, change in growth. The Greek word in the New Testament for repentance is really metanoia, to change your mind. Change your mind. Change. Change. Change your metanephrines. So all this is really saying is, what is the metabolic breakdown products here? What is the metabolic breakdown products? Plasma catecholamines. Catecholamines is epinephrine and norepinephrine. Now, there's one thing here. You ready? You have a person who's got episodic. Now this next, ready? Boop. The following 30 seconds is for people looking for the 95th percentile. Those looking just to pass should go get coffee right now. The following information is not necessary just to pass. It is for those looking for the 95th percentile. Boop. Now, what happens if you have a person with episodic hypertension, flushing, wheezing? You know that they got pheochromocytoma, right? You know they got a pheochromocytoma and the CT scan is negative. You got positive VMAs, positive catecholamines, positive epinephrine, and the CT scan is negative. Wow. What is the test that you should use next to detect the pheochromocytoma? Which of the following is the most accurate test now? You know they got it. They got palpitations and episodic hypertension. They've got VMA, metanephrines, and high catecholamines, but the scan is negative. What is the most accurate test at this time? And the answer is the MIBG scan, which I will spare you for what it means. Okay? MIBG scan is a scan that you use to detect the presence of occult pheochromocytoma when the initial CT is negative. And you ready? Now, this is why, if you think about it, I got a recently came out with a set of flashcards for USMLE. USMLE flashcards, the 200 diagnostic test questions you're most likely to see. Because that's the basics. What those flashcards were is that after 10 years or more, 15 years in classes, I started when I was in utero, okay, after 15 years in classes, I realized that this method, what's the most likely diagnosis? What's the best initial test? What's the most accurate test? What's the best initial therapy? Well, what if you take those 2 questions, what's the best initial test, what's the most accurate test, or the bottom line thing is this, what is this test and when do I answer it? When is it the answer? It took a long time for me to realize that some people would be just interested in a box of flashcards at just those answers. That was the basis of those USMLE flashcards. Those USMLE flashcards are based on that question. It's Conrad Fisher in a box. It's me in a box. Look, it's me. I'm in a box. Let me out. It means that basically, what is that test? That is a test for occult pheochromocytoma. It is picked up by enterochromaffin tissue, and it is excreted through that tissue there. Ready? When do I answer it? Story like pheochromocytoma, negative CT. Story like pheo, negative CT, answer MIBG. Story like pheo, negative CT, answer MIBG. What is this test and when is it the answer? That's the bottom line on that is. That's what those flashcards are. What is this test? Osmotic fragility. What is this test? The cells swell up and they pop. When is it the answer? It's the most accurate test for hereditary spherocytosis. Heinz bodies. What is this and when is it the answer? Prussian blue staining. Most accurate test for somebody who's got sideroblastic anemia. All right. Now the treatment, alpha blockers. But what do we mean by that? Phentolamine and phenoxybenzamine. Phentolamine and phenoxybenzamine. Now, Cushing's is never going to be a diagnostic difficulty because people with Cushing's, they don't present just with hypertension. It's like, ho-de-do, I'm just walking in and all of a sudden, hypertension, really? I've got Cushing's? Is that why my face is like a moon? And I have stria? And I'm covered with hyperpigmentation? Which happens? No, people come in with Cushing's disease, and it's in addition to the Cushing's, they're also found to have hypertension. Now, Cushing's disease is a primary adenoma of the pituitary secreting ACTH, and you get hypertension because ACTH makes cortisol. Cortisol causes increased vascular reactivity to epinephrine and norepinephrine. In other words, if you have vascular tissue without cortisol, there's much less of a response to adrenaline, to epinephrine. So you add the cortisol, and there's much more response to adrenaline, to epinephrine. In addition to that, you also get in Cushing's disease aldosterone effect. Now, the reason that you get stria and impaled healing is because corticoids, glucocorticoids, inhibit protein production. They inhibit protein production because they want those proteins, the amino acids, to be turned into sugars. Gluconeogenesis, glucose new formation. And that's why it impairs protein production, because it takes amino acids and converts them into sugar. Now, Cushing's disease also gives ecchymoses because it impairs the formation of collagen in the skin. Ooh, yucko, yucko. In addition, oh, moon face. Now tell me why it is that corticoids, glucocorticoids, can cause you to have lipolysis, dissolve lipids, yet at the same time it makes them build up in your face. How can it cause lipolysis and lipid formation in strange places? No one knows. No one knows. No one knows why you get lipolysis, and here, stria, straightforward, inhibits collagen production. So Cushing's disease is diagnosed by an overnight dexamethasone suppression test as the best initial test. Cushing's disease gets diagnosed by an overnight dexamethasone suppression test. So, righty, the best initial screening thing is at 11 o'clock you give 1 milligram of overnight dexamethasone suppression test. Now, if this test is negative, that excludes Cushing's disease with fairly high certainty. If that test is positive, that means it still might, that is Cushing's disease, but it doesn't give you the etiology. The etiology is determined by ACTH levels. If that ACTH level is high, it is a pituitary problem. If the ACTH level is low, it means it's either an adrenal problem or an ectopic production of glucocorticoids. And that's how you diagnose Cushing's disease. Cushing's in a nutshell. Now, by the way, did you ever wonder why you don't start with the scans? Why not just scan the brain, man? Why not just CT that brain and CT those adrenals? Why not just do that? Why not just start with scans? Well, did you know that like 1 out of every 15 people in the population has some sort of abnormality in their MRI of the pituitary? Do you know that if you start out with a scan and you find a little blip on the pituitary and you cut out the pituitary, that it could be that the problem was in the adrenals and that person just had a little pimple on the pituitary? That has happened to people. Somebody went like this: look, we scanned you, we found an abnormality in your pituitary, we cut out part of your pituitary, and we found that the problem was really in your adrenals. Oops, sorry. So in endocrinology, we start out with a functional test first, because it turns out that adrenals have a lot of incidentally found tumors. How would you like it if your adrenal got cut out and you really had a pituitary problem? I suspect you're going to say you wouldn't like that. How many people here said they'd like it? Adrenal cut out? Adrenal? 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 Make it like sashimi? Oh, we have tuna, salmon, and adrenal flavored sushi and sashimi. No, nobody wants to have sashimi made out of their adrenal glands. So you can't start with the scan. The reason that most people find this hard to understand is because it's not said in advance that the anatomy does not tell us the function here. Everything else, anatomic abnormality, must be functionally abnormal. Got a lung cancer, lung mass, bad, that's evil. But the incidence of masses or abnormalities found in the adrenal and pituitary is so high that you have to say, no, the problem is coming from the pituitary. Now we scan it. What do you see? If you start out by just scanning, you're not going to find the right thing. You're going to cut out the wrong thing. You're going to cut out the wrong thing. Function first, anatomy second. That's rare. That's what people don't understand. Now, other causes of secondary hypertension: contraceptives, acromegaly, congenital adrenal hyperplasia, just as we said. Now, the therapy for patients, let's look at these different classes of antihypertensive medications. Now, here we have, let's look at these drugs. Chlorothalidone, metazoline, and dapamide have the honor of being three different diuretics hardly used by anybody. For blood pressure control, it's hydrochlorothiazide, 1958, and it's going to be hydrochlorothiazide in the year 2008. Loop diuretics, all three of these are equal. Potassium-sparing diuretics, they're all equal. However, if you think about it, the top three, the hydrochlorothiazide, furosemide, spironolactone, those three diuretics account for 98% of all diuretic use in the United States. Now, the antihypertensive medications, look at these, what a large collection. Do you know that there's something like 14 approved beta blockers, not all of which are used for hypertension? There's 4 or 5 used for the eye, like Timolol, Timoptic, Timolol, used for the eye for glaucoma. But there's 14 approved beta blockers, and that's not counting combinations with calcium blockers and diuretics, separate individual generic chemical substances. Enormous numbers. Now, that means that although there are 50 separate approved medications for hypertension, it's still diuretics number one. If the diuretic doesn't work, you can either use a beta blocker, a calcium blocker, an ACE, or an ARB. If the person has another medical problem, a compelling indication, forget that thing about diuretics and go to the compelling indication first. Compelling indication first. They have congestive failure. Forget about the diuretic first, ACE and beta blocker. Myocardial infarction. Forget about the diuretic first and use a beta blocker for the coronary artery disease. Nephrology doesn't change. The things that we say in nephrology, we may be saying them better than we did 15 years ago. The tapes have evolved. The tapes get to be remade. We have new things to do, new ways of explaining it, new ways to show it, but the data doesn't change. So nephrology is largely unchanging. It's not like infectious disease. Infectious disease, there's practically a new infectious disease every other year. This past year, 2006, was one of the only years that did not have a new infectious disease epidemic. 25 years ago, there was no HIV, no Legionnaires, no Ebola, no hantavirus, no Ehrlichia, no Lyme, and the list goes on. In the last 25 years, there's been 20 new major infectious diseases. Lyme, Ehrlichia, several types of Ehrlichia, okay, HIV, Legionella, hantavirus, Ebola, none of which were around 25 years ago. So infectious disease has new diseases and new medications. Cardiology, new medications. 10 years ago, we told you not to use beta blockers in congestive failure. Now we say they're one of the most life-saving things. Now we use spironolactone for congestive failure. Used to use it for congenital adrenal hyperplasia before. Now we use it for congestive failure. New medications all the time. The first angioplasty was only in 1979. Now there's millions and millions. So there's new treatments all the time. But nephrology largely stays the same. Why do I phrase it like this? So that you can see it feels small. When you can feel it is small, it feels obtainable for you. Did you know that yours is the most knowledgeable year ever to come out of your medical school? That you are the most knowledgeable year ever to study for USMLE Step 2? This year is the most knowledgeable year. Because I went to medical school in 4 years, and you went to medical school in 4 years. But you have much more to learn than anybody who went to medical school 20 years ago. 15 years ago, there were no protease inhibitors. Now there's 9. 15 years ago, there's 1 statin. Now there's 7. 15 years ago, there's no angiotensin receptor blockers. Now there's 6. That's hundreds of different drugs more. That makes you the best, the peak of the generation, the highest output that has ever been there before. You're like at the top of a mountain. Don't you feel special?